Welcome back to the deep dive.
Mm.
Today, we are opening a file that I think a lot of us in the clinical world have mentally labeled, pending obsolescence. We are talking about the Nuchal Translucency scan.
The classic 12-week scan, yeah.
Exactly.
Yeah.
And let's just address the elephant in the room right up front. In modern obstetrics, with cell-free DNA and NIPT being so incredibly precise and readily available now, there's this massive temptation to just ask, is the NT scan obsolete?
Right, why bother?
Yeah, do we really need to be struggling to measure a tiny pocket of fluid behind a fetal neck when we can just draw maternal blood?
It is the question of the decade, honestly. And if you only care about Down syndrome, the answer might actually lean toward yes. But we've got a massive stack of new data here today.
Specifically the 2026 update based on the FMF and ISOGA 2025 standards.
Exactly. And that data says if you stop scanning, you are missing a huge part of the picture.
There is a specific number from the source material that really anchors this whole discussion for me.
Oh, the 34%?
34%, yeah.
If you take literally one thing away from this deep dive, you need to make it this number. 34% of congenital abnormalities in fetuses with an increased Nuchal translucency are missed by cell-free DNA alone.
That is just a staggering gap in care. Essentially, over a third of the clinically relevant issues are entirely invisible to the blood test.
Invisible, completely off the radar. And that really is our mission for this deep dive. We need to unpack these new 2026 protocols because we are witnessing a paradigm shift.
A total shift.
Right. We're moving from the traditional era of the 90s and 2000s where NT was just a screen for trisomy 21.
Just a Down syndrome check.
Exactly. We're moving into the modern era, 2025 and beyond, where NT is officially viewed as a broad fetal health marker.
So it's no longer just about counting chromosomes. It's about assessing the physiological health of the fetus.
Precisely.
Let's start with the why behind this, because for years, the clinical reflex has been pretty simple. High NT equals high risk for Down syndrome. And if the NIPT comes back low risk, we call the patient and say, good news, false alarm, you're fine.
Right. Everyone breathes a sigh of relief and moves on.
But the Gadsbill study from 2025 suggests that might be a very dangerous assumption.
It's an incredibly dangerous assumption to make. The Gadsbill study is fascinating because it isolated a very specific group. Fetuses with a high NT, defined as 3.5 millimeters or greater, but who had completely normal cell-free DNA.
The exact group we would usually just reassure and send home.
The very same. But Gadsbill found that in this specific cohort, there was still a 4 to 5% risk of pathogenic findings on a chromosomal microarray or major structural defects.
5% is huge in our world. That's 1 in 20.
It's huge. And this forces us to look at the biology. Why is the fluid there in the first place? We really have to stop thinking of it as purely a genetic marker and start thinking about the actual pathophysiology.
Right. The source material highlights 3 main drivers for the fluid buildup: cardiac dysfunction, lymphatic delay, and extracellular matrix issues.
Let's dig into the cardiac side because that's critical.
Yeah, the material talks about transient heart failure. What is physically happening to the fetus at that stage?
Well, think about the developmental timeline. Between 11 and 13 weeks, the fetal heart is undergoing massive remodeling. If there is even a slight inefficiency.
Like the heart isn't pumping effectively against the resistance of the placenta.
Exactly. You get back pressure.
It's basically a plumbing backup.
A plumbing backup is a great way to visualize it. That increased venous pressure transmits backward into the lymphatic system of the neck, which is still developing, causing fluid to leak out and accumulate. So that increased NT, it's actually a sign of transient heart failure.
And oxidative stress plays a role in there too, right?
It does. Abnormal development of the extracellular matrix, the scaffolding of the cells, that can also trap fluid. So when you see a thick NT, you might be looking at a baby with perfect chromosomes, but they are in heart failure. Or they have a skeletal dysplasia, or monogenic syndrome like Noonan syndrome.
There is a Venn diagram in the notes that I think visualizes this perfectly for anyone trying to conceptualize it. You have 3 overlapping circles: common aneuploidies, major cardiac defects, and genetic syndromes.
And increased NT sits right dead in the center where they all overlap.
That's the key takeaway for you listening. A normal NIPT does not clear a fetus with a high NT. If that fluid is thick, it is a glaring red flag for structural or syndromic issues that the blood test simply cannot see.
Which brings us to the practical reality of our daily clinics.
Right, because if we are now saying that this scan is a diagnostic marker for heart defects and rare syndromes, the pressure on the operator to get that measurement exactly right is incredibly high.
It has to be flawless. This isn't just casual screening anymore. It is high-stakes triage. And honestly, the 2026 update gets very strict about this. We aren't just looking for fluid behind the neck. We are talking about high-precision biometry.
So let's walk through the non-negotiables. If you are a clinical lead auditing your team's images, what are the absolute prerequisites before the sonographer even places the calipers?
First is the gestational window. It is rigid. 11 weeks plus 0 days to 13 weeks plus 6 days.
Which corresponds to a crown rump length, the CRL, of 45 millimeters to 84 millimeters.
Correct. If the baby is too small, under 45 mil, the structures aren't developed enough to assess. If it's over 84, the lymphatic system has likely developed enough to drain the fluid, and you've missed the window entirely.
But the real art is the image acquisition itself. You need the perfect mid-sagittal plane.
Perfect is the key word.
Mid-sagittal is one of those terms that gets used loosely in practice. I've seen plenty of images that are mostly profile, maybe a little oblique. The new standards require 3 very specific landmarks to prove you were actually in the dead center of the brain.
Extremely specific landmarks. You can't just see a generic profile. You need 1, the echogenic nasal tip, 2, the rectangular shape of the palate anteriorly.
And the third one is the big one.
The third one is the absolute quality control game changer, the diencephalon.
Let's pause there for a second. Describe what we're looking for with the diencephalon, because I think a lot of sonographers still gloss over this in the rush of a busy clinic.
So the diencephalon represents the thalamus and hypothalamus region. On the ultrasound, in the exact midline, you should see a translucent structure, basically a small black space inside the brainstem area.
And if you don't see it?
If you don't see that little black space, or if instead you see the bright white lines of the choroid plexus or the lateral ventricles, you are parasagittal. You are off-center.
Meaning you're slicing slightly through the hemisphere rather than the midline?
Exactly. And if you measure the neck from that parasagittal angle, your numbers are totally invalid. The skin thickness varies as you move laterally. You must see the diencephalon to prove you are dead center.
That is a really specific check to keep in mind. What about magnification? I still see scans come through where the fetus looks like a tiny peanut in a giant sea of black.
That is an automatic fail under the FMF and ICRO 2025 standards. The head and thorax must occupy 75 to 100% of the screen.
So we need to be aggressively zooming in on the machine.
Aggressively. You have to remember, we are measuring in tenths of a millimeter here. If you aren't magnified, a slight movement of the trackball, just one single pixel on the screen, can change the measurement by 0.2 or 0.3 millimeters.
Which is enough to move a patient from a low-risk pathway to a high-risk pathway.
Exactly. It changes the risk calculation from 1 in 1,000 to 1 in 50 overnight. You cannot afford that margin of error.
Related to clarity, the notes also explicitly mention gain settings.
Yes, turn the gain down. If the image is too bright, the skin line becomes fuzzy. It blooms.
And then you end up placing the caliper into the fuzz, rather than on the true anatomical line.
Which almost always leads to undermeasuring the fluid. You want crisp, distinct lines, almost like a stark line drawing.
Okay, so we're zoomed in, the gain is dialed down, we clearly see the diencephalon. Now we face the pitfalls. The source material calls one of them the amnion trap.
Ah, yes. This is arguably the most common reason for a false positive referral.
Because at 11 to 13 weeks, the amnion, the sac surrounding the baby, hasn't actually fused with the chorion yet.
Right, it floats freely in the fluid, and on ultrasound, it looks like a very thin white line, which often rests right behind the fetal neck.
So if you aren't careful, you end up measuring from the fetal skin all the way to the amnion, rather than just to the skin of the nuchal fold.
Exactly. You are essentially adding the width of the amniotic fluid pocket to your NT measurement.
Which creates a massive false positive. How do we avoid that reliably in practice?
Patience. You literally have to wait for the fetus to move. You need to see the baby bounce away from the ampion. When the fetus kicks or extends, you will see the clear separation between the skin of the neck and that floating membrane. If you don't see them separate, you cannot measure.
Speaking of the baby moving, fetal position is the other big variable. The source contrasts flexed versus hyperextended. Clinically, does this really make a significant difference in the final numbers?
It matters more than most people realize. If the fetal head is hyperextended, like the baby is looking up at the stars, it stretches the skin on the back of the neck.
And that artificially increases the NT.
By about 0.6 millimeters on average.
0.6 millimeters is the difference between a totally normal 2.8 and a frightening 3.4.
Precisely. You could end up sending a patient for invasive testing purely because the baby happened to be looking up.
And conversely, if the chin is tucked down hard onto the chest, so a flexed position,
That compresses the fluid space and decreases the NT by about 0.4 millimeters, which is a potential false negative. You miss the pathology.
so the rule is mandatory neutral position.
Mandatory. The head should be perfectly in line with the spine. You should see a little fluid pocket between the chin and the chest, but they shouldn't be touching.
And if they are touching,
You wait. Ask the mom to cough. Wiggle the probe a bit. You simply cannot measure a flexed fetus.
okay, so we've navigated the pitfalls. We have the perfect neutral image. Now we place the calipers. This is where I think people get tripped up the most during audits. Are we measuring outer to outer? Inner to outer?
It is strictly the on-to-on rule, inner to inner. You place the calipers on the inner echogenic borders of the translucent space.
So the horizontal crossbars of the caliper.
Must merge entirely with the white border.
Yeah.
You don't want them sitting inside the black fluid space, and you don't want them buried deep in the white line. They need to sit exactly on the interface where the black meets the white.
And the protocol dictates measuring 3 times. Right.
Yes, measure 3 separate times and record the maximum satisfactory measurement.
Not the average. The maximum.
Never the average. We are looking for the worst-case scenario to ensure safety. We want to catch the pathology, not average it away into normalcy.
That makes total sense. Now let's shift gears to what I think is the most clinically and emotionally challenging part of this entire update, the gray zone.
The 3.0 to 3.4 millimeter dilemma.
Yeah. For a long time, the hard cutoff in everyone's mind was 3.5 millimeters. If it was under 3.5, we'd say, well, it's a little high, but it's probably fine.
But the new data from Grow et al. In 2025 paints a very, very different picture.
It's a sobering study. Guo found that in fetuses with an NT strictly between 3.0 and 3.4 millimeters, this range we used to be quite relaxed about, there was a 31.5% rate of adverse pregnancy outcomes.
31.5%. Let that sink in. That is nearly 1 in 3 pregnancies in that zone having a major complication.
It completely shatters the old idea that this is a safe range. We used to treat NT as a binary toggle, normal or abnormal.
But the Bianchi study, also from 2025, shows us it's actually a linear relationship.
Right, their graph shows the risk line just climbing steadily from 2.5 millimeters upwards.
Exactly. Even in that supposedly normal 2.5 to 3.4 millimeter range, the risk of a major structural anomaly is about 1 in 30.
So emotionally and clinically, this changes the counseling conversation entirely. We really can't just reassure patients in this zone anymore.
No, we absolutely can't. You can't look at a patient and say, oh, it's 3.2 millimeters, just barely above the line. Don't worry about it.
Because that range carries a statistically significant residual risk.
Right. We need to frame it very carefully for them. We say, this isn't a red alarm, but it is an elevated risk that warrants a much closer look. It's about honesty and proactive care.
So what exactly does that closer look entail now? Let's walk you all through the 2026 policy directive, the actual management algorithm, because this is what clinical leads need to implement in their departments tomorrow.
Okay, so they've tiered it into 3 specific categories now. First, you have standard risk, which is an NT of less than 3.0 millimeters.
That's business as usual.
Correct. Standard contingent screening, biochemistry or routine cfDNA, whatever your local protocol is.
Then we hit the elevated risk tier,
Right.
3.0 to 3.4 millimeters. This is where the protocol fundamentally changes.
This is the new battleground for maternal fetal medicine. If you see 3.0 to 3.4, the required action is a detailed anatomy scan plus a fetal echo.
And for genetic testing.
You don't just offer standard NIPT anymore.
Yeah.
You offer genome-wide cfDNA or invasive testing with a chromosomal microarray, a CMA.
That is a big step up in intervention. Invasive testing is listed as a conditional recommendation there, but it's strongly advised because of that residual risk we just discussed.
Correct, because remember that 34% gap we opened the show with? A lot of those anomalies, the tiny microdeletions, the duplications, they live right in this gray zone.
And a standard NIPT that only looks at chromosomes 13, 18, and 21 will come back totally normal.
And you will completely miss the diagnosis.
Which brings us to the high-risk category, an NT equal to or greater than 3.5 millimeters.
This is an immediate invasive diagnostic testing recommendation. We aren't messing around with screening blood tests here. We need a CMA microarray, and specifically, we need to run a rhesopathy panel.
Can you explain the rhesopathy panel for our listeners who might not order them daily? Why specifically rhesopathies?
Sure. With that panel, we're looking primarily for Noonan syndrome and related spectrum disorders. These are caused by very specific mutations in the RAS-MAPK signaling pathway.
So they are single gene disorders, not large chromosomal missing pieces.
Exactly. And they cause heart defects, developmental delays, and distinct facial features. And crucially, Noonan syndrome is highly associated with increased NT and lymphatic dysplasia in the first trimester.
It's one of the most common causes of a huge NT in a chromosomally normal fetus.
Yes. But standard NIPT misses it completely because, again, the chromosomes themselves are perfectly intact. It's a tiny gene mutation.
So if you see a 4 millimeter NT and you just send a basic NIPT, you are effectively flying blind regarding Noonan's.
You are handing out false reassurance. If the NT is above 3.5, you have to sequence those specific genes.
And the surveillance for this high-risk group is also non-negotiable. Detailed ultrasound and a dedicated fetal echo.
Yes, heavily mandated because of that cardiac link we discussed at the start.
Before we move off the clinical management, I want to briefly touch on secondary markers. The 2026 update mentions using other ultrasound signs to refine the risk in these borderline gray zone cases.
Yes, the secondary markers are fantastic tiebreakers. If you're sitting at 3.1 millimeters and you're unsure how aggressive to be with your counseling, look at the other markers. Is the nasal bone absent? Is there tricuspid regurgitation in the heart?
And what about the ductus venosus flow?
The DV is critical. Specifically, we look for the reversed wave.
Remind us of the hemodynamics there.
So the ductus venosus is the shunt that connects the umbilical vein to the inferior vena cava. It accelerates oxygenated blood right toward the fetal heart.
And a reversed waves means?
It means blood is actually flowing backward during atrial contraction. That implies the fetal heart is stiff or can't handle the volume load being pushed into it.
It connects right back to that transient heart failure concept.
Yeah, exactly. It is a very strong, highly specific marker for cardiac defects. It pushes you from a maybe worry category to a definitely worry category.
Okay, let's look to the future. Segment 6 of the outline covers future horizons. We're moving away from subjective, one-time certification where you pass a test once every 5 years.
Thank goodness. Yes, we are moving to continuous statistical benchmarking. Specifically, the quality assurance framework is adopting CUSUM charts.
Cumulative sum charts. Explain how a CUSUM chart differs from the standard annual audit we're all used to.
It is a real-time drift analysis. In a standard retrospective audit, you might look at a bell curve at the end of the year.
But by then, you've already scanned 1,000 patients.
Exactly. The COSUM chart, however, tracks your measurements scan by scan, continuously plotting your median.
So it detects behavioral trends as they happen.
Yes. Let's say you inadvertently changed your screen gain settings, or you slightly altered your hand position, and you start consistently undermeasuring the NT by just 0.2 millimeters.
The CUSUM chart will flag that downward drift immediately.
Right away, long before it becomes an ingrained habit. It keeps you accurate in real time. The target median MOM, or multiple of the median, is always 1.0.
And if you drift too far from 1.0,
This system flags you, and you get pulled for retraining. It ensures that every single operator in a clinic is measuring exactly the same way.
which is vital for equity of care. And of course, we can't talk about the future without talking about AI. Slide 18 outlines AI integration. Are the robots coming to take the probe out of our hands?
Not entirely yet, but they are definitely becoming our co-pilots. AI is proving to be incredible for automated plane recognition.
It can find that perfect mid-sagittal plane with the diencephalon faster than we can.
Often, yes. And for caliper placement, it standardizes the whole process. It totally removes the subjective, I think this is the edge human element. The AI mathematically places the calipers on the exact pixel interface.
That's amazing. But there's a really fascinating study by Mattarelli et al. From 2025 regarding early NT that I think is the most exciting part of this AI discussion.
This study is groundbreaking.
This was the one about scanning before 11 weeks, right?
Yes. They used high-res ultrasound and AI to look at NTs at 10 weeks, technically before the official measurement window even opens.
And what did they find?
They found that if the NT was abnormally increased at 10 weeks, it strongly predicted adverse outcomes, even if the NT completely resolved and looked normal by the time they did the 12-week scan.
Wait, really? So the swelling physically goes away, but the predictive risk remains?
Exactly. It suggests that the transient physiological event, that early heart failure or the lymphatic delay, it happened. It signaled a profound problem.
But the body compensated.
Right. Even if the fluid reabsorbs and the baby looks quote-unquote normal at 12 weeks, the underlying genetic or structural pathology is still there.
That is genuinely mind-blowing. It implies that by waiting for the classic 12-week window, we might actually be seeing patients after the critical physiological event has already resolved.
It begs the question, is the 12-week scan actually late? Are we missing the peak of the pathology by rigidly sticking to the old window?
That is wild. But for now, at least, the AI is validated purely as quality support, ensuring we catch these things consistently when they're visible in the standard window.
Correct. It's a tool, not a replacement for clinical judgment.
So, bringing this all together, we started this deep dive by asking if the NT scan is obsolete in the age of cfDNA. I think the answer is a resounding no.
Absolutely not. It has a dual function now. It is a risk modifier for aneuploidy, helping us interpret those blood tests. But more importantly, it is a direct marker for structural and genetic morbidity.
We're talking cardiac defects, skeletal dysplasias, Noonan syndrome.
Things that NIPT simply cannot ever see.
But there is a massive hurdle here, isn't there? The clinical implementation. We're talking about rolling out elevated risk pathways that require genome-wide cfDNA or microarrays for a huge chunk of patients. That is incredibly expensive.
It is very expensive. Slide 19 explicitly discusses this economic impact. If we implement this new elevated risk pathway for everyone measuring between 3.0 and 3.4 millimeters, healthcare systems need specific funding attached to it.
Otherwise, we just create a massive health disparity.
Exactly. You end up in a situation where only wealthy patients get the Rasapati panels and the deep genetic counseling, while everyone else gets standard care.
Equity and access to genetic counseling are clearly going to be the big battles of 2026.
Knowledge is only valuable if it's actually accessible to the patient sitting in front of you. We desperately need the systemic funding in place to support these new protocols.
Well said. So as we sign off, I want to leave you, our listeners, with that provocative thought based on the Mattarelli study. If AI can detect an early NT at 10 weeks, that predicts outcomes even after it resolves.
Are we approaching a future where the classic 11 to 13-week window is actually missing the most critical chapter of the story?
If the fluid is a transient marker of a developmental crisis, catching it at the peak might be infinitely more important than measuring it when it's convenient for our clinic schedules.
It is definitely the space to watch over the next few years.
Something to mull over before your next clinic shift. Thank you for joining us on this deep dive into the new era of fetal imaging.
Always a pleasure to be here. Keep measuring precisely.
We'll see you next time.